I'm Helen Cross, Professor of Childhood Epilepsy from London, and I'm here to talk about neurodevelopmental outcomes following epilepsy surgery in childhood. There is no question that we feel that epilepsy surgery in childhood can be very beneficial to selected candidates, namely that we should achieve the primary outcome aim of seizure freedom or at the very least seizure reduction. However, when children are brought to us for evaluation, there are often many other aims that the family may have, not least with regard to neurodevelopmental progress and optimising their neurodevelopmental potential, but also with regard to possible behaviour improvement. And we need to look at the data we have to establish what advice we may give and what expectations we may have following surgery. However, when we look at data and when we're trying to evaluate whether there will be neurodevelopmental benefit, there are certain methodological problems that occur in looking at cohorts of children following epilepsy surgery. Following children over a long period of time after such an intervention can be quite problematic, not least because it's multidisciplinary and quite expensive. There is also often an argument that even when we're following such children, we have no control group by which to compare, no evidence on what the natural history of their neurodevelopment might be should we have not intervened. There is also a lack of standardised tests covering the complete age range, which isn't only problematic because of following children in the longer term over a period of time, but also because the range of children coming to us for epilepsy surgery go over a wide neurodevelopmental level and range, and therefore that can be problematic in trying to determine which tests may be the most appropriate. We know that early seizure onset leads to long-term neurodevelopmental problems. And these two graphs show data from two studies that emphasise this point. The graph on the left, looking at data from 100 consecutive children presenting to the Cleveland Clinic for epilepsy surgery, which showed, just determining their IQ, that the earlier the onset of epilepsy, the lower IQ. And indeed, if they presented with epilepsy under the age of 2 years, they were highly unlikely to achieve an IQ of above 70. The graph on the right is from a group of children evaluated for epilepsy surgery and who went for temporal lobe resection in London, and again shows the earlier of onset of epilepsy, the lower IQ at presentation for surgery. Most longer-term neurodevelopmental studies following epilepsy surgery demonstrate very little difference on a group basis between pre- and post-operative IQ. This could be argued to be a benefit in view of the fact you may presume that an IQ may go down over time if they're making little progress relative to their peers, and therefore if they have a stable developmental velocity, then we have achieved some degree of success. But why is it we cannot seem to see developmental gains? If we look at children who are operated on very early in life, that may give us some clue. Certainly, studies have shown that a shorter duration of epilepsy does lead to a better neurodevelopmental outcome post-operatively. And this data seen in this study, again from Cleveland, where they looked at children operated on under the age of 3 years, you can see that the shorter duration of epilepsy was associated with a greater chance of neurodevelopmental gains post-operatively. They also showed, however, if there was a history of infantile spasms post-operatively when seizures had stopped, they were more likely to show gains in the developmental quotient. And this could suggest that such children have evidence of an epileptic encephalopathy, namely ongoing epileptic activity, which is reversed immediately with the surgery and therefore shows sooner gains in neurodevelopment. Then if we look at how old the children are who come for epilepsy surgery, from the ILA survey performed in 2004, you can see that 60% had presented with epilepsy by the age of 2 years. But they underwent surgery over a wide age range, and indeed only a third came to surgery within 2 years of onset. So we could argue that perhaps we're not seeing significant gains in neurodevelopment following surgery because we're not operating on these children soon enough. However, there is some other data suggesting there may be a secondary factor. This is a study whereby children who had operated on in childhood or under the age of 16 were followed long-term following temporal lobe resection and compared with a group who were evaluated for surgery, offered surgery, but who did not undergo surgery for a variety of different reasons. And you can see a stable developmental velocity was seen up to a point of 6 years, at which point there appeared to be neurodevelopmental or cognitive gains. This is quite some time after surgery and perhaps a longer period of surgery than earlier studies. This was highly related to coming off medication. So it may be that we have two groups, those who have a degree of epileptic encephalopathy who improve immediately after surgery and maintain a velocity thereafter, and those who perhaps don't immediately show gains but show stable velocity and show gains quite some time after surgery, either due to coming off medication or perhaps a degree of reorganisation. There is no question the spectrum of children coming for epilepsy surgery is wide. Our primary aims in all children remain seizure freedom or indeed seizure reduction following surgery, but we accept that there may be secondary aims which may be neurodevelopmental gains or indeed behavioural improvement. The evidence suggests that in the very least there is sustained functioning following surgery, stable developmental velocity. If not, improved if we wait for a period of time. Much can be gained from early referable and possible intervention, but much can be lost by waiting. That aside, the goals of each individual are individual to that particular case and requires full exploration prior to surgery with the families and appropriate counselling given.